globally, where Tagrisso is not necessarily available at all, let alone readily available. And even in our own practices, where we have a range of options, we now have 2 clinical trials that have looked at Iressa, gefitinib, alone or with chemotherapy, carboplatin, and Alimta, pemetrexed, a regimen that most of us would strongly favor as our chemo of choice for adenocarcinoma, that have shown not just a progression-free survival benefit, but an overall survival benefit, and not a little one, but a very substantial one. And I think in many parts of the world, that is a very important, appealing choice. We have largely said in the US, we want to avoid chemotherapy for these patients as long as possible, but an argument can be made that you're hitting the cancer from a different angle and potentially killing different cancer cells. And the synergy could be quite substantial, whether with first generation agents or Tagrisso. Tagrisso is in clinical trials, but in the meantime, do you think that there's any play for chemo plus an EGFR inhibitor outside of a trial? Is that a strong choice, an option, or a very secondary choice for you?
I'm going to go first.
Sure.
So I think it's something to talk about, right?
Mm-hmm.
So we have 2 trials that looked at that question. One trial was done in Japan, and it was designed in such a way that the patients who started on the gefitinib Iressa alone had to go to chemotherapy as their next line of treatment, and that was provided.
Mm-hmm.
And they looked at that group as having a progression time 1 when they stopped the TKI, the oral medication, and a progression-free survival 2 when they'd had sequentially the EGFR drug and then the chemo. And then they compared that to the other group where they got everything together. They got the EGFR drug plus the chemo, and that progression-free survival was sort of the progression-free survival 1 plus 2. So it was sort of separately, sequentially, EGFR drug, then chemo,
Basically,
or everything all
together. How long of a
Right.
time elapses, whether you got them concurrently or sequentially?
And those numbers were almost exactly the same. Whether you got them sequentially or concurrently, that time to progression of having had all of those drugs was almost exactly the same. But despite that, the survival was clearly better for the group that got everything all at the same time. And so that has been a little bit puzzling to sort out, except you could say, well, you killed off more cells from the beginning. And so even though the cancer started to grow sooner, you'd given people a survival benefit, right? The other trial was done in India, and it's a little more complicated to interpret because the patients who got the chemo plus the gefitinib Iressa definitely got all those drugs.
Mm-hmm.
But the people who started on just the gefitinib Iressa, many of them never actually got chemo because of availability of chemotherapy. The healthcare system there is much more complex.
And a lot of those patients were sicker. There were a lot of patients with a marginal performance status that we usually exclude from these trials.
And so my take home from that trial was, if you're in India, you're better off getting everything at the same time if you can get it all covered, right? Because you might not be able to get your next line of therapy. But if you're in a different healthcare system, it's harder to interpret. So the Japanese trial still has me puzzled. And it's something I would talk to, especially for a patient who, say, has a really high disease burden, where you really need to kill off as many cells as possible, with this idea that the more cancer cells that continue to exist, the more opportunities you have for, in that next division process, a new mutation to happen, which makes resistance occur. That's true, right? So if you kill more cells at the beginning, less opportunity for those events to happen, less complex tumor, the argument's there. That being said, most patients still don't want to get the chemo at the same time. And so this is not something I've started to do yet, even though we've talked about it sometimes. Yeah. And with the osimertinib, those questions come in. Now, there's been publications. My colleague Joel Neal had a poster at ASCO this year looking at osimertinib plus chemo. And this was given to Tagrisso chemo for patients where we added the chemo to the osimertinib Tagrisso because they had their brain metastases controlled and we didn't want to lose that. Mm-hmm. Then we added chemo because they were growing elsewhere. So it wasn't something we did as a standard of care. It was something in unique situations. But we showed that that actually was tolerated pretty well. So it helped to support the studies looking at, should we be doing that more often?
Yeah.
All right, long answer, but.
And what are your thoughts, Carolyn, about chemo and EGFR inhibitor? Is that, are you optimistic about that, or do you think that defeats the purpose of the promise of targeted therapies to be chemo free as long as possible?
Well, as an evolutionary biologist kind of at heart, I am fully subscribed to the idea that TKIs are not going to be the solution to finding a cure. And that really we need to focus on a multifaceted approach. And chemotherapy is a bit of a blunt instrument, but it is an effective one. We still use it. It works. Doesn't discriminate whether you have, one kind of submutation or another. And so I do think that there is a role for that. Is that the question that remains is how to apply it. Do we do it right at the outset? Do we start the tyrosine kinase inhibitor, whether it be osimertinib, Tagrisso, or erlotinib, Tarceva, whatever it is, and get to a point of sort of maximal response where the tumor shrinkage has plateaued and then add chemotherapy? Do we wait until the tumor has started growing again and add it at that point while continuing the TKI, which was sort of addressed in another study? But I think that there are still so many questions that are really important for us to answer. And then on top of it, I think one of the things that we struggle with in the clinic is that there are all these sub approaches that we can take too for patients whose cancer is really well controlled, except there's this one spot growing in the liver, or
Right.
and then we use a targeted therapy or like a radiation for those spots. So